sixth session, which is an active learning session. Today we are going to discuss about the soft tissue surgery. At the outset, I should like to give you the outline of our today's session. We will be discussing about the decision making, which is probably one of the most difficult part in cerebral palsy, because we know everything, but when it comes to application of the knowledge, that is where most of the people are fumbling. So we are going to discuss something on that. After that, we will be going to our individual muscles, and then we will discuss when to carry out a surgery, some tips about the surgical technique, and then we will also discuss the post-operative protocol, which is very important for the soft tissue procedures. How this session will help fellows? That's a very important question. And the most important thing is there are two major mistakes which we make in cerebral palsy treatment. Is either a wrong timing of the surgery, means at inappropriate age we carry out a surgery, either too early or too late, or the second, we carry out a wrong surgery. So we will understand both the aspects from the interaction, and the concept which Carl Graham described in the 2010 OCNA chapter, that's a proper dosage. But this is a new name given to the concept which Benjamin has also described in his book of the decision making, that he has given we will do this surgery for this particular case. If there is this thing, then we will go to option B, option C. So that is what we are also going to discuss in related to cerebral palsy. It's rightly said that good decision comes with experience. I am sure everyone agrees with that. But the second part of that is also equally important, and that is the experience comes only after learning from the bad experience. So this is a very important thing. And at this stage, I would like to have feedback from Benjamin that in your life, in your practice, how did you got the experience for the good decision?
No, it was amply clear that not a lot of people were very conversant with cerebral palsy. So there were very few books to read at the time. You had Samuelson's book, you had...
No, but still, have you had any experience where you have made a bad decision? And
yes, of course. And we've seen the results of bad decisions. One example that I can take is there was an equinovarus deformity in a hemiplegic. So I did a complete transfer of tibialis posterior. And it went into overcorrection, and I had to undo the transfer. So here is a clear example of overdoing something. So I followed a few principles. One is, do the least that you can do. Do something that is least invasive to begin with. Do something that can be reversed if necessary, so that you don't burn any bridges. If you follow that dictum, you are not likely to mess it up too badly. The only disadvantage of that is you may have to intervene on more than one occasion. Maybe the dosage is not good enough, so you might have to go and do something more. I think that's better than overdoing it and getting harm and burning a bridge.
Okay, so basically, I'm very happy that you also have a bad case, because that's a very important message for the beginners, that always there are some issues with the decision making and we make wrong decision. I don't encourage them to make wrong decisions, but it's very important to understand that even Professor Benjamin Joseph has also made a wrong decision, and this is how we learn. So that is a one important message. And I would also like to tell my personal story. The first case of cerebral palsy which I did, I had a very poor knowledge of cerebral palsy at that point. Even at this stage, I have a very limited knowledge, but at that point, my knowledge was very, very primitive. And I operated that child, and the first child had a complication. And then that complication really taught me and made me to go into the depth of the subject. And I must appreciate, and I must show the gratitude to Benjamin Joseph, that his words were really very very sober, and like that really made me to understand the problem which, or the complications which has happened, and how to come out of that complication. So let's continue with the importance of decision making. It's rightly said that decision is more important than incision. I think the Professor Mercer Rang said this sentence, and he made this sentence very popular. I look at the cerebral palsy person like this. They are walking on a rope. Like this person, they have a very narrow safety margin. And any error here and there can make them fall or lose their walking ability. So this is one thing which is very important, that whatever we decide, we really ensure that we are not creating more harm to them. The good decision needs information, and there are various sources from where we get information. So we get information from clinical examination. We get information from gait analysis. I don't mean gait analysis means computer gait analysis. The video gait analysis also gives a lot of information. And in some of the cases, the X-rays and the CT scan, they are also powerful source of information. So ultimately, based on these sources of information, we decide something. So this sentence, we already see that good decisions comes with experience, and experience comes from learning from bad decision. Freeman, what is your take on this sentence?
Yeah, I mean, this is excellent. I think the whole process of good decision making, in addition, requires understanding the natural history of the deformity or condition that you are evaluating, and trying to understand sort of its development. And definitely there is nothing that has improved my understanding more than follow-up and learning from how things went. And typically the bad decisions you learn more from than the good decisions, because the goal is not to make more bad decisions.
Right. So that's very right, that we definitely learn from our bad decisions, and those bad decisions forces us to think that why we made a wrong decision. And actually during that period, the wisdom or the experience comes, and that probably helps us in the later cases for making a good decision. So let's have one case which has really taught me a lot. So this is about a female girl who is 11-year-old. She's a diplegic, GMFCS level 1. I'm going to show you the video. The question which I want the fellows to answer is that where is the problem, in which segment the problem, whether it is at the hip level, whether it is at the knee level, or whether it is at the ankle level. So that is what the question. I request you that please don't speak up, observe the video for 30 seconds, and then we will have a discussion on that. Okay, so I request fellows to unmute yourself and then tell us where is the problem, whether the problem is at the hip, knee, or at ankle level. Yeah, Arun, please.
Problem is mainly at the knee level.
At the knee level. Devendra, okay, Devendra's reply is like problem is at the knee level, right? Anyone has a different take on that?
Yes, sir. The child is walking with apparent equinus.
Yes.
So once we correct the apparent equinus with some AFO, the child can walk straight, sir.
Okay, good. So like what will be your line of treatment for this particular case? AFO or as Devendra said, that doing something at the knee level?
Sir, here the problem is lever arm dysfunction, sir.
Okay.
So if the tendon is very spastic in this case,
right.
So So once we do some antispasmodics and physiotherapy along with AFO, the child can improve, sir.
Okay, good. So Arul's suggestion is to go for anti-spasticity medicine, AFO, and to look at or like to control the ankle. Devendra, what is your like? Why do you say the problem is at the knee level? Because if the problem is at the knee level, then there is no point of going for AFO. Yes, Devendra. What is your argument and why you suggest or say something contradictory to what Arul said?
The knees in flexion in the entire swing and stance phase of the gait cycle.
Right.
Also,
Yeah, Dr. Khatri, if you want to add something, then you can also say.
Sir, I think, good evening, sir.
Yeah, good
Sir,
evening.
I think, sir, the patient needs to be examined. Is both the hips, knees, and ankle should be examined first, and then we should be taking any decision regarding his treatment, sir. Because this kind of a gait could be caused by either the problem at hip, knee, or ankle. So we should have a proper clinical examination first, rather than just the gait analysis, the visual gait analysis.
Okay, I appreciate your point and agree with your point completely that only on this video we cannot make a decision. I agree with that. But still, if I insist you that what you see where the problem is, or what is your guess, where is the problem, whether at the hip, knee, or ankle?
Sir, the video has become hazy, but the child walks with the jump gait, sir. His ankle is in equinus all through the gait, sir.
Right.
So we'll have to assess whether the equinus is dynamic or it's a fixed equinus, sir. If at all it is a dynamic equinus, then only AFO is going to help. Otherwise, we'll have to think of something else.
Okay, good. So let's move further and see and understand the thing is. So this was in 1997, 25 years before. And at that point, the technology of video recording and everything was not that great. Now we can record video in a mobile camera. At that point, I used to have a VCR or like the tap type of camera. And on that, we used to record. So I accept that the video quality is not that great. But okay, let's see. This is a stop frame video. And now if you look at this, this is just before the stance phase, the beginning of the stance phase. And at that point, this video is frame or this frame is stopped. And now if you analyze this, this is what the situation is. The knee is in flexion and ankle is in neutral position. This is just before the initial contact. What should be the position of knee at that particular point in a normal child?
During initial contact, there
full
should be
extension.
10 degree of flexion.
It should be full extension.
Full extension. So now if you look at this video or this picture, can you see something about the hamstrings?
Very tight, sir.
They are
Very
Hamstring
tight.
is tight.
Okay, good. This is about the right side, and this is the same video of the left side, the left lower limb. And again, if we see, the ankle is in neutral position and the knee is in flexion. This is again in the terminal swing just before the initial contact, where ideally the knee should be in a full extension. Let's understand this slightly in more detail. So to make you understand, I request Read 9 Prime to mute yourself. Yeah. So let's understand in more detail. Now we are trying to, in this animation, we are looking at the right side of the lower limb. And this is how what happens in the lower limb, that is what is shown. So limb moves like that in the swing phase. And the last picture shows that the hip is in flexion and the knee is fully extended. If you look at the hamstrings, which is on the back side of the hip and back side of the knee, this is a position where the hamstring has to stretch maximally. This is the position of the gait during which the hamstring is stretched maximally. If there is a hamstring contracture, what happens? That we will try to understand. If hamstring is short, it will not allow the knee to extend fully. Now, if you look at the ankle is in a neutral position, but still, if you look at the ankle, it appears that there is an equinus, but there is no equinus at the ankle. It appears as equinus, and that's why this is called apparent equinus. So one of the feature or the salient feature of short hamstrings is it leads to apparent equinus gait. And in apparent equinus gait, surgery on calf, which is not the culprit, where there is no problem, and if you carry out surgery on the calf, it leads to disaster. So I think we stop at that point, and before we move on to the interaction, I would ask Benjamin first and then Freeman about their views on the phenomena which we discussed, the apparent equinus. Yeah, Benjamin.
Yeah, I think it's vital to identify the apparent equinus, which you see very well illustrated in this case. The right lower limb actually was even better. The second one you showed slowly. The ankle actually goes into a bit of dorsiflexion. So in such a situation, you're really asking for trouble if you lengthen. If you lengthen it at all or touch it. So stay far away from it. And as far as the hip is concerned, there is no excessive lordosis, suggesting that there is probably no flexion problem at the hip. So I think it is primarily a problem related to the knee. There is some tightness of the gastrostomus, which is actually probably advantages, not disadvantages.
Yeah, Freeman, what is your...
Yeah, I agree with all the comments Benjamin just made. I think the one thing that the hamstrings are the primary problem, but often the gastrocnemius is also contracted. And as you come to full extension, there's a benefit to leaving the gastrocnemius a little tight, but you have to be careful that it's not too tight. Or if you lengthen the hamstrings, you get into back kneeing, especially if the patient has no flexion contracture. So I think that it requires a careful assessment, and absolutely the soleus has to be protected. So if there's any gastroc lengthening, it has to be very conservative and very proximal above the conjoint tendon of the gastroc and soleus to protect all of the soleus, which is clearly not contracted in this case, I think.
Okay, good. So let's understand something about the decision making before we go to the actual surgery. I would like to ask Freeman first, like you have the facility of computer gait analysis. So my question is like, do you suggest computer gait analysis to all the patients who are undergoing surgery or only limited patients?
At this point, we have a sort of rule in our facility that all the patients who are having surgery related to gait improvement should undergo gait analysis. And also even patients for whom, say, we're going to do dysplasia, but they have surgery, hip dysplasia surgery, but they are ambulatory and have CP, we recommend doing it. In part, as for some patients, I think it provides less direct diagnostic benefit, but we are very interested in having that for ongoing follow-up. so we can look back that we have objective evidence of where we were when we started.
Okay, that's very important point. You said that gait analysis has a definite advantage of follow. After surgery, definitely the pre and the post analysis gives you a lot of information, whether your assumptions was right or wrong, and whether you are able to achieve the result which you have anticipated before surgery. But related to decision making, I would like to ask you a question. In how many number of patients, I want a rough answer, like say 5%, 10%, where you have really changed the decision related to surgery after gait analysis?
I think, yeah, my estimate would be it's probably a third of the patients. We see a different pattern. We see things that maybe were not picked up initially on the physical examination and observational gait analysis. Sometimes, and of that, probably it splits about evenly between patients that we say, oh, you shouldn't do that, or you've maybe not noticed this problem. And typical things are the asymmetries in rotation related to pelvic position, which are very hard to see in patients because of often they have clothes on and when you're observing them walking. Rotational alignment of the femur relative to the tibia is another sort of common problem, as well as these issues related to hamstring length versus gastrocnemius length, because the pelvic tilt is another thing that's a bit hard to see. We can see lordosis, but then we even have some patients that are very hesitant, to be walking when we can actually see their back. They might have a big shirt on or something. So I think we suffer from lack of our observational gait analysis ability due to some of those sort of social criteria, social issues, especially with adolescents.
Okay, thank you. Now I would like to ask Benjamin about the reality of India, where only few centers have the facility of computer gait analysis. The question is like, how many times you have asked your patient to undergo gait analysis before surgery?
The history of treatment of cerebral palsy in my center was in the early 90s. I had a very simple gait analysis lab. I didn't have a force plate. I had only kinematic analysis. I had surface EMGs, which were picked up by telemetry. So that's all I had. And I tried to decipher what I was doing. And I realized that I need more than that. I got money to run that for about 5 years. After which, when it had to be upgraded and force plates put in, we didn't have funding. And the institution would not pay for it. So that was the end of gait analysis for me. So for several years, there was no other center which did it. And so there was no question of my getting a second opinion. So it had to be clinically only.
Okay, but if I ask you in that case, when like at that point, you practiced from say like 1990 to 2010, in those 30 years, probably there was no gait lab in India. But in how many cases you really felt that if I have a gait analysis, then probably my decision making would be better?
I don't know.
10%.
I could never really know that because I didn't see the advantage, or I didn't see the benefit of computerized gait analysis in my patients. So I didn't have a group of patients on whom I had made a tentative diagnosis and tentative plan, and then done gait analysis and found that I changed it. Like Freeman was saying, that it changes in about a third. So it is quite likely that I got it right in only about 2/3 of the patients, because that's the number that Freeman was quoting. And there's certainly a possibility that I underdid or overdid some stuff for the remaining 1/3.
But yes, like in those 1/3, let's the hypothetical 1/3, the post-operatively, definitely you would feel that this is not what you have expected.
Yeah.
Have you felt like that?
I must say that though we quoted the numbers, I honestly don't think that I really messed up in 1/3. Most of the patients got some benefit, but they might have got a greater benefit if they had the benefit of analysis. So I don't think we went completely off track, but I think it could have been fine-tuned. And so that is something that we need to keep in mind, that we may not get it perfectly right. And so we just can't throw up our hands in India because the numbers are so large to say that without gait analysis, I won't undertake surgery on a child whose gait is abnormal. We just have to proceed prayerfully and hope that we would not mess it up.
Okay. Then we give a lot of emphasis to examination under anesthesia. Now, the question I want to ask Benjamin and then Freeman, in what percentage of patient you really change your decision making after examination under anesthesia? Particularly when you have decided that you are going to carry out a gait improvement surgery on this child, and how many times you really have to change your decision?
Currently, I'd say very few instances. I mean, towards the latter part of my career. But in the initial part, yes, when I was in doubt whether it's a severe spasticity or contracture, anyway, we plan some surgery, we take them into surgery, and I would do an examination at that point. And just check that we are not making a mistake of thinking that it is spasticity when there is a true contracture, or think that there's a contracture when it's only spasticity. So yes, in the early part of my career, I think there were times when a significant number of children whom we might have changed our opinion. But over time, I think we got a little better in clinical assessment. And so I don't think there were a lot towards the latter part of it.
Okay, and at that point, you used to carry out examination as a separate procedure, or just before the surgery?
Just before the surgery, because again, that's an issue of cost.
Cost, yeah, I understand. And Freeman, what is in your practice, in how many percentage of patient you had to change your decision after examination under anesthesia? Because as you said that in most of your patient, there is a computer gait analysis, so you have a much better source of information. Yeah.
So there are two places where the examination under anesthesia, I think, continues to be important. And certainly like this girl we just showed, even though you have all the data and have a pretty good concept what you're going to do with the gastrocnemius, examination under anesthesia in that case, I think, is still very important. Not so much to decide whether to do it or not to do it, but where to do it, how much to do it, to either be very cautious or a little bit less, more proximal, less proximal relative to the location. And the other area that I use a lot is deciding on the need to do a tibial derotation in the face of planovalgus foot correction. But in that situation, it's more you correct the foot. Once the foot is corrected, you're never quite sure exactly how much that's correcting rotation. Then you do a careful assessment to decide whether the tibia should be done. And usually in that situation, the gait analysis maybe has suggested that the tibial torsion is a problem, but then you correct the foot and you see after the foot correction that, no, this looks fine. Or on the other hand, you say, boy, we didn't get so much correction. Yes, it does need to be corrected. Those are the two main circumstances where I rely a lot on the examination under anesthesia to make a decision.
Okay, good. So now we move on to the, if fellows have any question, you can raise hand and we will take your questions. So feel free to ask questions. Now we come to the soft tissue surgery. The current concept is the ideal age for the soft tissue is 6 to 8 years. Now, in case of adductors, I have seen that many of the children, when they start walking and say around 3 or 4 years, they have a scissors gait. Now, do you go for adductor surgery before 6 to 8 years, or you wait for 6 to 8 years? Because unless and until we clear the seizures, the gait is not going to improve further. So what is the right age for adductor surgery? Benjamin and then Freeman.
Again, I would like to delay it if I can. But if there are situations where there are much younger children who got very severe adductor spasticity on whom we are forced to do something. But we be conservative in what you're doing. Don't overdo it again. One of the problems with doing it early is that you might have to repeat it somewhere a few years later.
Okay, and Freeman, what is, according to you, the right age for adductor surgery? I'm talking of GMFCS 1, 2, 3, not 4 and 5.
Yes, and I think, again, it's dependent on the x-ray. For if the hip x-ray is showing subluxation, then for me, doing the adductor surgery, is indicated primarily for the hip, but with a goal of also improving the gait. So you sort of try to modulate the two. I think there are circumstances where you do have very severe adductor spasticity, a normal hip, and it's sort of blocking the child's progress. But very often, you have a child who is starting to walk, they have a lot of adductor spasticity, it seems to sort of be in their way, and that's an indication sometimes where I would use a Botox injection, or just sort of patient perseverance and not rush too quickly to do adductor surgery. There are people who advocated, Michael Sussman as an example, strongly advocates this as very, it's a very rewarding surgery because often the children do make dramatic progress. And it's sort of operating at the time the children are getting better anyhow, to sort of give them a little boost makes you look very good. But I worry about having to redo it, or that if you just have a little patience, oftentimes they outgrow it and they gain control of that problem.
Okay, then about the indications, what are your criteria for deciding for the adductor surgery? Benjamin and then Freeman.
If, as Freeman said, if there is hip subluxation, well, that is an indication straight away. The second is if there is scissoring with an inability to abduct beyond 30 degrees, then I consider surgery.
Right, okay. Freeman, for you?
Yeah, very often it's a combination of rotational malalignment and adductor spasticity. Typically, also the medial hamstrings are involved. So I don't have exactly specific criteria. I use more how the child is progressing. I typically, when the concern is raised, I ask the family to give it 6 months and with therapy, and let's see how the child is doing. If they seem to be stuck and not making progress, then for me, that's a bigger indication.
Okay, good. Already we have discussed this point, but I'm asking again to re-emphasize. We discussed this in the clinical examination that we have a flap test for differentiating between the medial hamstrings and adductor, that we check the hip abduction with knee extension and knee flexion. At that point, we discussed that both of you said that you carry out a surgery of adductor longus and gracilis. So is there any indication where you have done only adductor surgery and you have not operated on the gracilis? Yeah, Benjamin first and then.
No, I've done it together because that's somehow I was taught to do that and I continue to do that. So I've not done an adductor longus without doing a gracilis.
Okay, just in addition to that, I would like to ask you, Freeman, that if we have to carry out both adductor and the hamstring surgery, in that case, we can carry out a gracilis myotomy at the adductor region, and we can also carry out the another option is to carry out fractional lengthening at the distal level along with the medial hamstring. So what do? Do you prefer to carry out myotomy, or you prefer to carry out at distal level when we are operating at both the thing, adductor and hamstrings?
Yes. If I'm doing both, I prefer to do the myotomy of the gracilis proximally, and then the myofascial lengthening of membranosus and tendinosus distally with the adductor longus proximally.
Okay, so you don't go for fractional lengthening or the aponeurotic lengthening of gracilis distally, because it's a very easy procedure.
Yes.
Than the myotomy, but still you prefer myotomy.
If there's a situation where I'd like to get a little bit of adductor lengthening, but I don't think the adductor is so very contracted, then I would do the distal lengthening of the gracilis. So it's sort of, I think you can do either one, and it depends. My sense is that the gracilis is a more powerful adductor than it is a hip flexor in many patients, because the center of its moment arm from the center of motion at the hip is most medial. So that gives it a very big adductor moment arm. And that's why I sort of would like to release it proximally if I'm trying to treat adduction in addition to hip flexion.
Right.
I mean, in addition to knee flexion.
Knee flexion, right. Okay, so basically doing a adductor myotomy at proximal level is more effective as far as the hip abduction is concerned.
That's my feeling, without much objective evidence.
Okay, good. Now another question, like when I started the cerebral palsy surgery, I used to read a Campbell, which was at that point a very standard textbook for surgery in orthopedics. And in that, the surgery which was described was an obturator neurectomy. What is the role of obturator neurectomy nowadays? Benjamin and then Freeman.
Very little now, indication now to do an obturator neurectomy. I agree that initially when years ago we used to do it, and in fact there were people who did truncal obturator neurectomy, not just the selective branches. So I don't see a lot of reason to do it. Maybe the occasional situation where you've got a severely spastic hip, which is subluxating and dislocating, I may consider doing adductor tenotomy along with my, obturator neurectomy along with my adductor tenotomy, which is very easy to do. And I would only take the anterior division off. But that is seldom, if ever.
And what about adding to adductor longus gracilis, the adductor brevis muscle in the procedure? Have you done that?
I have done that in adolescents who are severely tight, because you just cannot get the hip straight. So yes, in that situation, otherwise virtually no.
Okay, yeah, Freeman, what is do you use phenol in the obturator now, or do you carry out obturator neurectomy, anterior division, or complete trunk?
Yeah, so just very much like Benjamin mentioned, in the severe quadriplegic child who's very spastic, as an example, a 3 or 4 year old with a hip subluxation of 60 or 70% that I'd like to delay doing a varus osteotomy or hip reconstruction, I would do an anterior branch obturator neurectomy, as well as the mostly in that case, adductor longus brevis and gracilis release. I think I don't use phenol, but it's reasonable to do that on the nerve. What I do sometimes, if I'm a little questionable, is I use what I call mechanical phenol. I isolate the nerve and use a hemostat and crush the nerve, which I think does the same thing as phenol. And it's important to recognize the anterior branches of the obturator nerve. Some nerves, if you touch them, like the perineal nerve, they want to stop working. Some nerves, you can hit them with a hammer and you can't get rid of them. And the anterior branch of the obturator nerve is one of those. It's very durable and you can crush it a couple times and it'll come back. But I think it's important not to do a complete release of the obturator nerve, as was advocated at one point, always preserving the posterior branches, which go to the adductor magnus and some to the medial hamstring. So, that's my what I had done.
If I may make it.
Yeah, please, sir.
If I make a comment, I must mention that early on in my career, when I was actually in training, I've actually seen more than one child who was ambulant with scissoring, who stopped walking because both hips went into wide abduction.
Yeah.
So you can overdo it, and it can be awfully dangerous because a walker can become a non-walker.
Yeah.
So
the rule that I use for anterior branch obturator neurectomy is only in the non-ambulatory. I would not consider it even in an ambulatory trial.
Okay, I'm coming to that question now, and that is, what is the difference in the dose of adductor muscle release for GMFCS 1, 2, 3, that's ambulatory group, and GMFCS 4 and 5? Is it the same dose that's adductor longus and gracilis, or you increase the dose of adductor release in GMFCS 4 and 5? Freeman first and then Benjamin.
Yes, I would definitely increase the dose, meaning I would more aggressively release. It also depends a bit on the severity of the hip dysplasia. So if you have a 3-year-old with 70% hip subluxation, then I would never do an anterior branch operator neurectomy if I felt the child would become ambulatory, even in that age, in that situation. But I might increase, and I would try to preserve some adductor brevis. But if I felt the child had no head control, was going to be a GMFCS 4 or 5, it's the situation where I then would do the sort of whole dose, often with medial hamstring lengthening, adductor longus, brevis, anterior branch obturator neurectomy, and gracilis. And in the worst case scenario, if you do too much, you get hyperabduction, and then you have to do a varus osteotomy. If you don't do enough, you can have continued hip subluxation and you have to do a hip reconstruction. So it's a balancing act, and I certainly have not gotten it right all the time. In fact, in those severe cases, I tend to, even though I do a very aggressive lengthening, almost always I still have patients who have recurrent hip dysplasia later. The CP quadriplegic, it's pretty hard to overdo it in the young age.
Okay, yeah, Benjamin, about the difference
again,
in
yes,
GMFC.
very conservative in ambulatory. Yeah, in GMFCS 1, 2, and 3, be conservative and cautious. In 4 and 5, aggressive.
But aggressive means like what is more aggressive? Adductor brevis?
I mean, be quite comfortable about releasing the brevis. Be very comfortable about releasing, dividing the anterior obturator division. So yes.
Okay, good. So now we come to the, like, doing surgery is easy as far as the adductor is concerned, but the question is about the post-operative protocol. Do you give them a wide abduction, means like a 30-degree abduction plaster with a rod in between, or you don't give anything after surgery? Benjamin and then Freeman.
I tend to put them in broomstick cast for 3 weeks.
3 weeks, okay. So till the wound heals, yeah, exactly. And Freeman, what do you?
We typically use encourage the family to use pillows. If the child wants to lie with knee flexion, then we use knee immobilizers, removable Velcro sort of closure knee immobilizers to keep the hip extended, and ask the family to, when the child sleeps, to always keep pillows between their legs to keep them abducted. And when they're up sitting, also. And most of the time, if you've done enough adductor lengthening, the legs will want to stay abducted. If after you've done it in the CP, especially in GMFCS 4s and 5s, if you've done adductor lengthening and the legs are still wanting to adduct, that's clearly a sign you haven't done enough.
Okay, and what is like the difference in the recurrence rate? Have you come across a recurrence of adductor problem after surgery, particularly walking ambulatory children? Yeah, Freeman and then Benjamin.
Yeah, so the recurrence in ambulatory children, I find to be very low, and if you're doing it for hip subluxation, the outcome is really quite good. If the child gets to be a functional GMFCS3 walker or better, we have more than 90% of, the last review that we did was like 91% of the patients had resolution of their hip subluxation. On the other hand, for the quadriplegics, the outcome is clearly less good. So we had 60% on our follow-up of patients who needed further surgery, mostly with recurrent adductor contractures and hip dysplasia.
Yeah, Benjamin.
My experience is that the younger the child, the higher the risk of recurrence. The greater the GMFCS level, the higher the risk of recurrence. They're diametrically opposite.
Okay, and then another problem which we have seen, particularly in non-ambulatory children, about the windswept deformity, which is probably a multifactorial problem. And what do you think, or what do you suggest so that we avoid that problem in GMFCS 4 and 5 group? Benjamin, what is your take on that?
Well, I don't know. This is a difficult issue.
Yeah, okay, Freeman. Yeah, I'm sure that you must have come across this problem.
I haven't seen a lot of windswept and that. You're telling me?
Yes, yeah. Have you seen that after?
We have, and I think with release of the adducted limb, it tends to get better. So I don't do a lot on the abducted limb. I don't know what Freeman does in that situation.
Yeah, Freeman, yeah, please.
Yeah, it is one of the most difficult problems, and it's especially difficult to sort of be predictive. And the cases, for instance, when you start with a 4-year-old who's got some significant asymmetry, a windblown deformity, then I tried to do an adductor lengthening that brings symmetry. That might mean a very aggressive lengthening of the adductor longus, brevis, gracilis, and anterior branch on the adducted side. And occasionally, if there's full abduction, none on the other side, or maybe sometimes just an adductor lengthening, longus and gracilis, if there's adduction present, they are not able to abduct to 30 degrees with knee extended under anesthesia. But on the other hand, I can tell you I have a number of cases where you do that and 2 years later, they wind blow the other direction. And then you try to, muscle lengthening, especially in the 9-10-year-old, doesn't work well. I agree, abductor lengthening doesn't work well. Usually it's varus osteotomies that I do. And that's probably for me the most effective way on the abducted side is to varus the hip, because those abducted hips often have extreme coxavalga.
Isn't there another issue that often is associated with scoliosis?
Yes, it is. In the later, as the child gets into adolescence, it is often associated with scoliosis. Then there's a debate about whether it's the windblown deformity that drives the scoliosis or that the scoliosis causes the pelvic obliquity, which then causes windblown deformity. And I think it can be both. Yes, in the teenager, that is definitely part of the problem. And in those cases, I think soft tissue lengthenings for me have not really worked very well.
Okay, so now we move on to the next muscle, that's psoas or the iliopsoas. So I request fellows, if you have any question, please raise your hand option and then ask question. Otherwise, we will continue with the next point, and that is psoas muscle. So the first question related to psoas muscle: what is your indication for carrying out a surgery of a psoas muscle? That's a first question, because over years in the past, I used to do a lot of surgeries on the psoas, but then I realized that it's not necessary, and without psoas surgery, we can get equally good result. So have you seen such change in your practice over time, Benjamin, and then Freeman?
Yes. I mean, I seldom, if ever, do a psoas lengthening in isolation. And it's usually in hips that are tending to subluxate or dislocate when I release the adductors and the iliopsoas. And again, the difference is, if it's an ambulatory child, I do release at the brim of the pelvis. And if it is a non-ambulant child, I do it at the lesser trochanter. When I'm releasing the adductor, it's very easy to do that through the Rudolph approach.
Okay, yeah, Freeman, what is your, like, have you seen such a change in your practice or not like that?
Yes, no, very definitely. In the 1980s and early 90s, I was doing a lot of adductor lengthenings for ambulatory patients, often combined with hamstring lengthenings, under the thought that we would prevent some of the anterior pelvic tilt that acutely occurs after hamstring lengthening. But since the late 90s, I probably, pretty much completely eliminated doing iliopsoas lengthenings. There's two reasons. First, there's not very much benefit when we look back at our gait analysis results. And secondly, in ambulatory patients, the iliopsoas is a very important hip flexor. And when you have problems with the gastroc and the distal muscles, you need the power from the hip flexor for both walking and going up steps. So I currently feel that it is very seldomly indicated in ambulatory patients, but I do in GMFCS 4s and 5s, non-ambulatory children, completely release it from the make sure you're above the apophysis so you don't get that muscle spike that occurs sometimes. But if you do want to release it because of significant hip flexor, or let's say the young child with hip dysplasia, I would do an intramuscular lengthening, making sure the iliopsoas remains intact.
Yes. So according to you, like now the indications of psoas lengthening has gone down. So what are your current indications for psoas surgery in ambulatory children?
I think for me, it probably is limited to the very young child who is GMFCS 1 and 2, in whom I am doing surgery for hip dysplasia. I think because it is a strong muscle, and I think it does contribute to hip dysplasia. I mean, this is part of still the thought process from years ago, training on DDH, where it was felt to be a significant deforming force. So it's maybe that is not such a good indication either, but I think it's been quite a few years, maybe 20 years, that I haven't done an iliopsoas lengthening to improve gait. If you have very severe hip flexion contracture that you think you should treat, I would rather do a hip extension osteotomy. but that's very rare in CP.
Okay. Then the tips, no doubt, the incidence of the requirement of Sowas lengthening has gone down, but still I would like you to suggest some tips to avoid femoral nerve injury while doing a Sowas lengthening, particularly over the beam technique. So which is your preferred technique for doing a fractional lengthening of the Sowas? Freeman and then Benjamin.
So I still prefer to do the inguinal approach. You can get to the same point, but you have to put a retractor up under the inguinal ligament, and then you can get a hold of the psoas muscle with the hip flexed a bit and pull it down. And you always see a very nice round, good muscle. And you're looking from the medial side, so you're seeing the tendon. You don't have to go through the muscle like you do if you come from the lateral side. And so that's still my approach, is to do it from the inguinal approach, but reaching up high underneath via the the adductor approach.
Okay, so you go from adductor approach, or the the medial approach side, which is medial side. So is it the same one which Dr. David Sutherland suggested, that you do a transverse incision over the inguinal ligament or just below that, and then please. So then
I do it. Yes, I usually develop the interval between the adductor, between the pectineus and the neurovascular bundle, and to go down in that interval between the neurovascular bundle and the adductor, pectineus and adductor longus. And then you come down on the iliopsoas, which is lying on top of the hip capsule at that point. It's similar if you were doing a medial approach to release the hip capsule or to drain a septic hip. You can also go on the medial side of the pectineus. That's another option. You can choose which one you do. But I find that quite simple because I'm very used to working in that area of the hip. And to me, it's more simple than the separate approach above the inguinal ligament.
Okay. Benjamin, what is your technique for doing the psoas lengthening?
I go anteriorly through a groin crease incision, and I go laterally. I go lateral. I identify the femoral nerve, retract it immediately, find the iliopsoas at the posterior medial aspect of the muscle belly, and release it at that level within the intramuscular. So I go laterally. I identify the femoral nerve, retract it immediately, and go under the retractor.
So in that case, we have to rotate the muscle, and then the aponeurosis is underneath the.
You have to rotate the muscle. Once the hip is flexed and it's a little relaxed, it's not difficult to do.
Okay. Then coming to the question about the post-operative protocol, because not very important in the case of adductor, but once we have done hip flexor lengthening or the psoas lengthening, if we allow the patient to be seated in the post-operative period, particularly 6 to 8 hours in a day, does it lead to more recurrence? So what is your protocol for the or after the psoas surgery? Benjamin and then Freeman.
Yeah, I mean, no special form of immobilization. Avoid pillars under the knee if we haven't done surgery on the distal part of the limb. Encourage lying flat on the back, as you know, for a reasonable period of time, and avoid sitting for too long for the first 3 weeks.
Okay, too long means like how many hours? Like, do you allow them 2-3 hours in a day?
A couple of hours a day is okay, but more than that, I discourage for the first 3 weeks.
And do you insist to lie down in a prone position for a few hours in a day?
I think it's uncomfortable, but yeah, it might be a good idea if the patient is comfortable about it. So I tend to let them lie supine.
Okay. Yeah. Freeman, what is your post-operative protocol?
Yeah, it's I do encourage, or try the therapist to get the family, teach them prone lying, to spend time trying to get them if they're sitting. I mean, most of these patients would be sitting a lot, so you try to let them get them out of the chair at least every couple hours and have them spend time prone lying. It is often a bit uncomfortable because that's what really is stretching it. But and then I also very much using knee immobilizers to keep the knees extended and flat if they're supine lying are the two main approaches we use to try to keep them stretched out.
Okay, and once there was a very big controversy about, or like the concern about the post-operative weakness, which does not allow the stair climbing. So what is the current status of that controversy? Is it solved or still it's a controversial issue? Yeah, Freeman, yeah, what is your...
I think it is, I think it is probably more controversial in the management of DDH. But I do think it's an important issue for the ambulatory child or adolescent with CP. And one of the reasons why I focus a lot on preserving the iliopsoas and avoiding lengthening. And if you're doing hip reconstruction, being very careful not to completely release it. If you do completely release it inadvertently by removing the lesser trochanter, you should reattach it. That's been my focus, because I do think it's important, especially in the GMFCS 2 and 3 spastic child, who often have poor plantar flexor response, so they can't augment their hip flexion with the plantar flexion push off very well.
Okay, and Benjamin, what is your understanding of these problems? The problem of stair climbing after surgery?
I mean, I haven't studied it specifically, but among the ambulatory children whom I've had to release the iliopsoas, I think they've managed to do so. My indication for releasing the iliopsoas is much more for the hips, which are subluxating. So that's a different ballgame altogether.
Okay, so now we move on to the most important and very commonly performed surgery, that is hamstring surgery. So we start with a very basic question about the indications. So how do you decide for the indications of hamstring surgery on the gait or on the clinical examination? Means on one particular proprietal angle, do you go for hamstring lengthening, or you look at the video which we saw in the beginning of the session, that if there is not adequate extension in the terminal swing, you go for hamstring lengthening? Benjamin, what is your decision making on that?
If the patient demonstrated in the beginning, we concluded that there is a hamstring tightness or spasticity, and if it is a true contracture, then I believe that releasing it judiciously is a good idea. I agree that in the early part of our training, we probably released hamstrings too radically, released both the medial and the lateral, and overdid it. Now I generally do only a semitendinosus, and if there's beginning of crouch and weakness of the knee extension, I transfer it straight away to the adductor magnus, so that there's no need to deal with it later. Transferring the tendon early is better than trying to lengthen it and do a transfer a few years later, because it's all fibrotic when you go in there. So if I find that I need to release the hamstrings, I take off the adductor longus and transfer it to the adductor magnus insertion, so that it acts as a hip extensor, which is something that you want. Right? So if the child is older, then I do a semimembranosus release. Try to avoid the biceps if I can. But remember that when the child comes to you as an adolescent for the first time, you may not be able to get the knee straight unless you even release the lateral hamstring. but that will be apneurotic. So you just do the apneurotic lengthening of semimembranosus and the biceps and do a transfer of the semitendinosus to the adductor longus. Gracilis has already been there to the hip level.
Freeman, I have a question. Like, again, I have seen the change in the surgery, the type of surgery for the hamstrings. When I started my practice in 1990, I used to carry out both medial and lateral hamstrings, even the biceps also. Then the article came which says that it's better that we leave biceps and we focus only on the medial hamstrings. Then I came across the concept by Paulo Selber and Kirk Graham about not doing anything for the semimembranosus and just transferring the semi-T to adductor magnus tendon, which Dr. Benjamin said. So what is the current or the ideal dose of hamstring surgery at this stage?
Yeah, I would like to start by saying I think there's the biggest area of current sort of flux is how to deal with hamstring problems and understanding the hamstring. It's a very complex muscle. And I think from my perspective, it is probably currently the least sort of, I think if you go around the world and talk to different CP surgeons, it has the biggest variability in how people approach it. So my approach, which has evolved only slightly, so that may mean that I'm stuck in the past, is to primarily indicate hamstring lengthening if the gait is showing lack of knee extension, as you showed earlier at foot contact. So it has to be primarily a gait parameter, and or you're developing a fixed knee flexion contracture. So those are the two things that I use as an indication for doing hamstring lengthening. Then the amount of hamstring lengthening is dependent upon the sort of two things: how much contracture is present, especially under the examination under anesthesia, and the condition of the foot and tibia. So if you have external foot progression, external tibial torsion, and developing crouch and a fixed knee flexion contracture, then that's a scenario where you're going to, in a, say, 10-year-old, really have the risk of progressive external rotation of the tibia and the foot, and leaving the knee unbalanced by doing just medial hamstring lengthening is something that I worry about. And that's the situation where I would do both medial and lateral. I would do the semitendinosus and membranosus myofascial lengthening, and then a myofascial lengthening of the biceps laterally, usually through the same incision. And do the goal is to reach an intraoperative popliteal angle of 30 degrees, never full extension, never a full zero popliteal angle. Now, the popliteal angle, when I'm talking about there, is not maximum force, but to where you feel the end of the muscle contracture. To be very cautious about not over lengthening, not so aggressively lengthening the hamstring that there's a zero popliteal angle. So that's my sort of current feeling. I recognize that there's lots of controversy with whether to transfer hamstrings to the adductor tubercle or not. I just haven't been convinced by the results that people have shown.
Okay. There are two major concerns about the hamstring surgery. The one is the pelvic tilt, the anterior pelvic tilt post-operatively. And the second concern is about the recurvatum. So have you come across this problem in your practice? Because the pelvic tilt can only be identified with the computer gait analysis. So what is your understanding after doing so many hamstring surgery? What happens to pelvis after hamstring surgery?
Yes.
Sorry.
Oh, I was just going to say the pelvic tilt acutely, the year after you do hamstring lengthening, typically the pelvic tilt increases maybe 5 degrees or so. If you then follow up 5 years or more later, the pelvic tilt has completely corrected again, goes back to where it was. The recurvatum, I think there are 2 reasons for getting recurvatum. One is doing too much hamstring lengthening, and the other is not doing balancing it with the appropriate amount of gastrocnemius lengthening or treating the equinus. So you have to be very careful to make sure you get the equinus corrected at the same time, so the 2 are balancing each other. But that definitely is a risk and something to pay attention to. And one of the reasons to be very cautious about not doing one of these very aggressive sort of complete releases of the hamstrings.
Okay. Yeah, Benjamin, what is your concept about this pelvic tilt and the recurvatum?
We have certainly seen some amount of increase in pelvic tilt after hamstring surgery. And it is my impression, and I agree that I have not quantified this with gait analysis, that when we do less in terms of release and transfer the semi-T to the back of the femur, I think that most of the patients don't develop as severe a pelvic tilt as we used to see. As far as recurvatum is concerned, I haven't seen a lot of them, except as I mentioned in one of our earlier sessions, if the gastrostosis is very tight and you haven't addressed that, the plantar flexor extensor couple works viciously and produces a recurvatum which is difficult to treat. So I think you should watch out and make sure that, as Freeman said, release the gastrostosis if it is necessary. Again, judiciously, not overlengthening.
Okay, and then the another concern is about the checking at the popliteal angle during surgery. The problem with me is like I used to do, or even still I'm doing hamstring surgery in a prone position. So in prone position, it is very difficult to check the popliteal angle. That is first concern. And the second concern, there was a paper which says that post-operatively, if you examine the popliteal angle, there are possibility of having a nerve injury or the stretching of the nerve. I think from the Robert K. or that institute, that was a paper that it's not safe to carry out or check the popliteal angle during surgery. So what is your understanding on these points?
Yeah,
Freeman, yeah.
I mean, yeah, I always do the hamstring lengthening in a supine position, so I can check that the amount of lengthening. And I don't think, I have never had a nerve stretch from doing a popliteal angle check in the operating room. The problem where we get sciatic palsies after surgery is when the physical therapists sometimes will have the child long sit or overstretch the child in the therapy session, because now the hamstring is weaker, and sometimes in a small child it's easy to get too aggressive with the stretching. So we specifically give recommendations to the therapist that the child should not be long sitting, and should also, if it's too painful, they need to back off, because the stretching the nerve causes pain, and you have to be very cautious to do that. So I think if you are getting a sciatic nerve palsy from stretching the nerve in the operating room, you are doing entirely too much stretching.
Okay, Benjamin, have you got sciatic nerve palsy or stretching palsy during surgery or like after surgery?
In 1979, one case, never after that, fortunately.
Right. So with that, we go to the next part, and that is a calf muscle. We have 15 minutes with us, and we will try to utilize those 15 minutes to understand the most important points related to calf surgery. So the first, before my presentation is ready, I would like to ask the fellows about what is their preferred surgery for the calf. Would you like to go for tendo Achilles lengthening, or Bulpies procedure or Stryers procedure? What is your preference for gastrosoleus lengthening?
Bulpies.
Bulpies, okay, right. That's Devendra, right?
Siddharth.
Siddharth and Devendra.
Siddharth and Devendra, right. Okay, Dr. Khatri, what is your preference?
Sir, at our institute, we perform Bulpies.
Bulpies, okay. Then Akash is also of the same opinion. Then Alur, what is your, or Vikas, what do you do at Vellore?
Sir, Stryers, sir, it is more safer as it is more proximal.
Okay, fine. So let's understand something about which is a preferred procedure. So the point is, the concept is that in diplegics, tendo-Achilles is not a good option. So this is what the thing is, and that is what the Vikas said. Vikas, can you explain why do you believe that it's a safer procedure, the Stryers is a safer procedure, and the tendo-Achilles is not a good option?
Sir, the more distal we go, the more correction or the tendency to overcorrect the deformity is more. So in these cases of calf lengthening, I would rather do some undercorrection rather than overcorrect. So Stryer being a zone 1 procedure is, I feel, is one of the safer than a Bulpies or a tendo-Achilles.
Okay, right. So let's understand something. I think that probably these pictures will probably have a more understanding or more discussion also. So in diplegia, the understanding is that the gastrocnemius, which is a biarticular muscle, is usually short, and the soleus is of normal length. I'm talking of a diplegic cerebral palsy children. When we carry out a tendo-Achilles lengthening, that procedure lengthens both gastroc and soleus. And what happens that because of tendo-Achilles lengthening, the gastrocnemius, which was short, will become of a normal length, which is what we desire. But the soleus, which was to begin with normal, after tendo-Achilles lengthening will become an over-lengthened muscle. So let us understand this by animation. The gastroc is shown in a red color because it is short. The soleus is shown in a green color because it is of a normal length, and the white is the aponeurosis and then the tendon. So this is about diplegic child. When we carry out a tendo-Achilles lengthening as shown over here, by whichever method, but when we carry out a procedure on the distal part, we are effectively lengthening both. We are lengthening the gastro and we are also lengthening the soleus. So the next picture is that the gastroc has now become of a normal length, and the soleus, to begin with, which was normal, has now become long. So now the question is, what are the side effects of unnecessary soleus lengthening? The unnecessary soleus lengthening, I think this is a paper by Scott Delp, which says that 1 centimeter unnecessary lengthening of the soleus leads to 50% reduction in the strength of the soleus. Why it is a problem? The strength of the soleus, why it is a problem? This picture tries to show that when we are upright, the tibia is vertical to the foot, and in that position, or for that position, the soleus plays a very important role. So when tibia is upright, the upper part, the knee and the hip, they are well aligned. When there is an unnecessary lengthening of the soleus, the tibia has a tendency to move forward, or the ankle to go into dorsiflexion. And once it goes in this position, compensatory knee is flexed, and that is probably the reason for crouch. So whenever possible, we tend to avoid the tendo-Achilles lengthening in diplegic children. So that was a point. Freeman, what is your take on that? The concept which I explained, is it okay, or you have to say something differently?
No, it's completely excellent explanation.
Okay, Benjamin, would you like to add anything to this or?
Nothing to add.
Okay, thank you. So we go to the next point, and now the question is, which surgery is a preferred surgery for diplegic? The first part said that tendoachilles is not a good option. So the next question is, which surgery? The Stryers is a preferred surgery for diplegic. The reason is, in Stryers, we go in a plane between the gastroc and the soleus. So the plane which is shown as a dotted line, we go in that plane, we separate out the soleus which is underneath and the gastroc which is superficial, and then we try to cut the distal part of the gastroc like this. So basically that separates out only the gastroc, and we are not doing anything to soleus. So after that surgery, what happens? The soleus remains like that because we have not done anything, and the gastroc, which was short, becomes in more length, and this gap ultimately heals by fibrosis. So Stryers procedure lengthens only gastrocnemius, and that is a preferred procedure for diplegic. Yeah, Benjamin, what do you think about this? And
Absolutely agree with you.
okay, and Freeman, what do you think about that?
Yes, I agree as well. There is a gradation of severity, and occasionally there are diplegics who have a little gastroc contractures. I mean, soleus
contracture.
So,
yes, yes.
Yeah, so you can move a little more distal and get into the conjoint tendon. And sometimes in mild cases, you might not want to completely release the gastroc. You might want to just release the fascia of the gastroc. So I think you can move up and down the scale depending on how much is needed.
Yeah, okay, we are coming to that point in the interaction. So now, which operation is preferred in hemiplegic? Because hemiplegia and diplegia has a different characteristics of muscle involvement. So what we saw in a diplegic, it's mainly the biarticular gastroc is involved. While in hemiplegic, both gastroc and soleus are involved. So as shown in this picture, you can see that diplegic, the soleus is normal, while in hemiplegic, both gastroc and soleus are involved. So in hemiplegics, doing a tendoachilles lengthening, where both muscles are short, the tendoachilles lengthening will give the equal amount of correction for both the muscles. So that is one preferred option for hemiplegic. Coming to the Bulpies procedure, Bulpies procedure is something slightly more proximal to the tendoachilles lengthening incision, and where we try to carry out the fractional lengthening of this muscle. And again, this procedure is very effective in correcting the problem of hemiplegics, that's both gastroc and soleus. So in hemiplegic, the tendoachilles or Bulpies is a safe procedure. Before we go for the one or two questions in the remaining time, we would like to have the homework for our fellows. So I want fellows to take a short assignment. The first question we want to discuss in the next presentation is, how does planovalgus deformity or the foot problem leads to crouch? Because next week we will be discussing crouch. So the first point is this. So who would like to take this question? Fellows, be quick.
I'll take it up, sir.
Yeah, Vikas, good. So Vikas will be taking about the planovalgus deformity in crouch. Good. The next is like, how does tibial torsion leads to crouch?
I'll take on.
Okay, Dr. Khatri will take the tibial torsion and its effect on the crouch. The third question is the femoral antiversion or the in-toeing problem which we see. So can femoral antiversion leads to crouch? That's a third question.
Yes, sir, we'll take it.
Okay, Devendra, good. That's a difficult question. And the last question is more of a general question, and it's more relevant in the today's scenario where obesity is increasing day by day. Can obesity leads to crouch? So who would like to take this a difficult question?
I'll take it.
Okay, Arul. So these are going to be the homework for next week. And in the time which is with us, we will have one question or two questions. Benjamin, what is a post-operative procedure, or during muscles? How do you check the adequacy of surgery, whether you have corrected it adequately or not?
To be honest, I don't do the popliteal angle on the table because often what I do for crouch gait is certainly enough to lengthen the hamstrings. I shorten the femur in conjunction with the rest of the deformity correction, which we'll discuss later. And so I don't actually test it to convince myself that it's been done.
Okay.
As far as the Achilles, as gastrosoleus is concerned, I like to passively dorsiflex to a few degrees beyond neutral to make sure that I've got adequate length.
Yeah, few degrees means what? How much? Because this is where the 5 degrees.
5.
Okay, right. The question why I'm asking this is the reason is because what we see at anesthesia, and when the patient comes out of anesthesia, during anesthesia there is no no tone, and when they come out and they start walking, the tone is different. So many times, like, we feel that probably we have undercorrected the equinus deformity. No doubt, undercorrection is definitely much better than the overcorrection. So, Freeman, how do you do, or what do you your endpoint for calf surgery?
For a gastroc lengthening, if I'm doing a gastrocnemius recession, I prefer to have, as Benjamin said, 5 degrees of dorsiflexion with knee extension, not more. When I'm doing a tendon Achilles lengthening for a hemiplegic, then I want the tendon to have some tension at neutral. So I like to repair it. So when I have the foot at neutral, at 0, that there's some tension on the tendon. And then I put him in a cast, with no dorsiflexion, especially if I do a tendon Achilles lengthening. And I try to do the same for the gastroc lengthening with neutral, no dorsiflexion in the cast.
The Freeman, the question I would like to again ask you the same question, because in hemiplegic, the recurrence is very common. So yeah, why you want to be like in a neutral position and not want to go into 5 or 10 degree of dorsiflexion? Because recurrence is one thing which family don't like. So
yeah, because of the weakness. And I think it depends a bit on the age. So I'm less concerned about that if I'm doing a 5-year-old or a 6-year-old. Then I don't think it's very difficult in hemiplegia to do overcorrection. So then I might give them a little more. But if you're doing a 15-year-old, you don't want to overcorrect a hemiplegic either, because they need to develop power in that ankle. And the risk of recurrence once you have completed growth is pretty small.
Okay, and then the last question is about the post-operative protocol, particularly when we are doing only the calf surgery. We are not doing hamstring surgery, only calf surgery. Do you give a below knee plaster or you give above knee plaster? Freeman, no, and then Benjamin.
A below knee cast, and I encourage them to walk on it and to use a knee immobilizer at night to keep the knee straight, so that the gastroc gets stretched.
Okay, Benjamin, what is your?
I tend to put a long leg cast with the knee in extension for 3 weeks.
Okay, and do you allow them to stand and walk on the plaster?
Generally not for the 3 weeks.
Okay, right. So I think that our time is already 6:29. So thank you. If you have any question, we can take one question quick. Because would you like to ask?
I have a question, sir.
Please.
Sir, after a stress release, we find that the amount of correction that we have got is less. It's not coming to neutral. So intraoperatively, what is the next step that we have to do?
Okay, that is what the Freeman said, that in that case, we need to lengthen the soleus fascia.
Okay.
Yeah.
Yes, sir. Thank you, sir.
Okay, thank you once again, Benjamin and Freeman, for your excellent input for this important question, and see you next week. Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you, sir.
Thank you, sir.